So, welcome everyone who's attending the webinar. Really great to see it's so well attended and the topics generated so much interest. So, my name is Rob Griffiths. I'm Director of the Mental Health Nursing Research Unit in GMMH, and I also work at the university. And this is a webinar presented by the Mental Health Nursing Research Unit and GMMH's Research and Innovation team. And we've got a really interesting topic today, and a group of researchers are going to talk to us about a project around care aesthetics, the art and craft of mental health practice for people with dementia. It's obviously a really important topic, really interesting topic. It's obviously generated a lot of interest because so many people have signed up for this webinar, which is fantastic. I'm going to hand over to Professor John Keady now to start the webinar and start the presentation, and other presenters will gradually introduce themselves over the course of the event. But over to you, John.
Oh, thank you so much, Rob. And hello, everybody. It's so lovely to be here. In one way, this is a bit of an ending of a 3 or 4 year journey when we started writing the proposal for this work at the time of COVID. And one of the wonderful things about this research is the interdisciplinarity of the team. We have theatre, we have drama, we have disability studies, we've got dance, we've got speech and language therapy, and we've got me as a mental health nurse. It's been a real pleasure to have been involved in this project for this length of time. And this webinar is largely based on the innovation, the creativity of Professor James Thompson, who's going to start our first presentation, looking at what is care aesthetics. Next slide, please. So James will actually start the webinar in terms of the talks, and then it will be followed by 3 separate presentations, but all by members of the team. We're focusing those presentations on care aesthetics in action, as it were, through the NHS and through healthcare, the practices of healthcare support workers. So from Jackie down to myself, we'll be largely focusing on healthcare support workers and care aesthetics in action. So I think probably the best thing I can do is hand over to James and to start the webinar. Thank you, James.
Thank you very much, John. I'm delighted to be here today to talk about care aesthetics generally, but also specifically about the research project that myself and the team have been developing over the last 3 years. What I thought I would do today is just to give a brief explanation of care aesthetics, or the sort of idea of care aesthetics, and then introduce the basic structure of the research project we've been undertaking before colleagues then describe particular parts of that project. One way of explaining the notion of care aesthetics is by actually looking at the cheap plug that I've done here on this slide, which is a book that I wrote in 2022 called Care Aesthetics for Artful Care and Careful Art. And you'll see the front cover picture. And many times that we present the idea of care aesthetics to different audiences, we will get different reactions to this particular picture. Now, I'm a professor at the University of Manchester, but in the drama department. And if you show this picture to drama students, dance students, or art students, they initially will see something that comes from the performing arts. They might see a dance tutor working with an elderly dancer, positioning their hand in a correct way so that they can undertake the next move, or a drama teacher working with a student to move them in a particular way. But of course, if I showed this picture to healthcare professionals, they see something very different. They will notice the uniform of the woman on the right side of the picture, her badge, indicating that actually she's a health professional working with this patient in a particular way to support his gait, to support his movement. I suppose the point of care aesthetics is to say that this overlap for us is something quite interesting. That's something that for one community could be an image that comes from the arts, for another community of professionals it's something from healthcare practice, suggests there is something similar between the work, the practice of artists and the practice of healthcare professionals. So care aesthetics is the term we use for this overlap. It's something not necessarily about arts in healthcare, but it's about the art or craft of healthcare itself. In terms of the origins of our interest, and my interest in particular in care aesthetics, it does come from physiotherapy. And actually the image we have here is a physiotherapist working with an older patient. Over 10 years ago, I was working in the Democratic Republic of the Congo. A colleague of mine, a Congolese colleague of mine, was badly injured there, and he ended up living with myself and my family while he undertook an operation and then post-operative recovery. I had to take him regularly to see his physiotherapist in the very painful process of physiotherapy after his operation. And I became intrigued in the relationship that he developed with this physiotherapist. She spoke a different language to him, and therefore there was a sort of communication between them that didn't rely on sort of spoken communication, but they developed a relationship through the way she worked on his body. Coming from the arts, I saw this relationship in a particular way. She used touch, she used breath, she used body posture, she used tone of voice, she used a whole way that she related to the man that I felt had a certain craft to it. It had a certain sensory or embodied quality to it that was quite extraordinary. I became intrigued in this because, in a sense, to me, it was an aesthetic practice. It was a craft-like practice. It didn't necessarily exist in a vocal relationship between them, but in the way that she moved, her poise, the grace that she had in building a relationship with this man. And these terms, this movement, this sensory or embodied quality of their relationship, for me was something aesthetic. Of course, the word aesthetic can be quite confusing, but for us, aesthetic doesn't simply mean the idea of something that is looked at. It's something that is about the quality of someone's appearance. But the word aesthetic is being used to explain all the bodily practices we have in the relationships we have with our friends, colleagues, or patients. The way we touch, the way we move, the way we breathe, the way we look at people has a certain craft, it has a certain embodied practice. And the claim here, I suppose, is that improvements in the aesthetics of your practice improves the quality of the healthcare that you're enabled to deliver. So I saw in this initial physiotherapy relationship a set of bodily practices, a certain craft of this physiotherapist that for me indicated that there was a certain quality through her embodied and sensory practice. And this led to a question that was, how might this framework, this idea of an aesthetics of care, help us focus on improvements in healthcare practice or delivery? And from that moment, I then was very, very fortunate that I met John Keady and Jackie Kindell, who have been speaking and will speak later today, because they were both specialists in dementia care. And between the three of us, we started developing the idea of what it might mean to use the framework of care aesthetics, particularly when working with people living with dementia. This was a really important area for us, partly because people living with dementia require a certain embodied or sensory relationship with the people that are working with them. There was a focus on person-centered care and relationship-centered care that then posed questions about how bodies work in different relationships and different spaces. And there was an acknowledgement, obviously, in the field of dementia studies that those relationships, those embodied and sensory practices were important for improving and developing high quality dementia care practices. And this then led us to develop a research project that would focus on care aesthetics as a framework for thinking through how we might value, but also improve the quality of relationships between care workers and patients in different dementia care settings. Can I have the next slide now, please, Emma? So with Jackie and with John and with some other colleagues, we developed a three-year research program exploring how this framework of care aesthetics, the idea that care can be looked at as a sensory or embodied practice, how it might be useful as a way of both valuing and then also documenting and noticing the quality care practices of different care workers. The project was organised across 4 different case studies. The one that you're going to hear most about today is with healthcare support workers in NHS mental health wards for older people, where we worked on 2 different sites, and you'll hear more about that in the rest of the seminar today. We also developed a case study in arts-informed care in a care home, and this was to try and compare the work of artists working in care homes for people living with dementia to care workers working in those contexts. We also then had a case study in London working with home care workers to look at the work of care professionals as they visit older people's homes and the type of embodied practical skills that they developed in those contexts. And finally, we wanted a community-based aspect of this project because most of the work was either in domestic spaces or on wards or in care homes. And therefore, we developed a final case study that looked at what we called food sharing practices with communities, how the aesthetics of the care of sharing food and enabling people to have better quality food might be understood through this particular framework. So those are the 4 case studies, and we developed those over the 3 years of the project. And we had a public platform throughout the whole of the project called the Care Lab, which sought to actually develop dialogue and debate about the idea of care aesthetics within dementia studies, within older people care, then in other areas of healthcare practice as well. So that's enough from me. And now I'm delighted it's Jackie Kindell for the next section. Thank you.
Thanks, James. So I'm Jackie. I'm a speech and language therapist. So already, while you've been listening to James, you've been hearing about how much this is about interaction and communication. So that's my particular interest in it. So I'm going to talk about the review that we did that perhaps sits behind some of the work to see what was written already about this area. So when we talk about healthcare support workers, just to be clear, we're talking about an umbrella term. There's obviously a variety of roles, variety of unregistered support staff roles in the NHS, but it might be nursing auxiliaries, OT assistants, speech therapy assistants, psychology assistants, etc. So these are unregistered staff who have supervision from registered staff, such as nurses, AHPs, etc. And a recent study found there were just 96 different job titles for support staff alone in mental health. And I kind of recognise that from my own career in mental health and developing new roles and new titles. So support staff in patient-facing roles are 28% of the NHS workforce. So they are a huge slice of our workforce. So really important. And then when we look at ward shift patterns, so when I talk to my colleagues in nursing, and there will be obviously perhaps different support, different shift patterns in different places, but it's clearly almost always there's more support staff than there are registered nurses on a shift pattern, and particularly at night, that it can be really quite stark, the different numbers as well. So it's really important as well to sort of think particularly in that ward context that we were looking at. So the next slide, please. So our review question, we wanted to look at the quality and quantity of research that explores people's experiences, healthcare support workers' experience of their everyday practice, and also training in the NHS in the UK. And we looked at the UK because support workers have got different qualifications and setups in different countries, and so sometimes it's not quite so easy to compare across. So we wanted to look at the NHS and UK in dementia. And we wanted to look at qualitative studies because we wanted to understand people's in-depth experiences. So what did people say in detail about their work? And through a systematic search using specific terms, we found 19 papers. So there were hundreds and hundreds of papers about dementia in hospital settings, but only 19 about support staff. And then when we looked through those, there were only 10 about mental health, inpatient, older adult mental health settings, and 7 came from the same data set. So literally only 4 studies really within this. So what we did was a thematic analysis. So we took all the quotes from interviews, everything people said about their job, and all the descriptions of people's work from observations, the ethnographic data, and we put them all, and the themes from the studies, and we put them all on a big Word document, and that went over 57 pages. And we kind of then worked out, well, what's jumping out? What is it? So we did a thematic analysis of this data. Next slide, please. And that's the reference for the paper, should you wish to read it. But there were 4 themes, these 4 themes that you see on the slide here. And I'm going to talk through these one by one, just very briefly, though. So next slide, please. The first one was roles and responsibilities, and you'll see in the paper there's that absolute breadth of things, stuff that healthcare support workers do, a whole variety of roles and responsibilities, and describing quite a wide range of tasks undertaken, from personal care to responding to people's safety to observation, all sorts of different things, aspects of the ward routine. Next slide, please. And then the second theme was really around practicing and reflecting. So it kind of went into more depth about how people describe the skills that were necessary for these tasks, and then some of the reflections on that. So Goodwin described healthcare assistants who sang while delivering personal care to a patient and chatted about all sorts of things. It's a really lovely example. Featherstone talked about, the time and skills it took to feed a person with dementia who was unable to eat independently. And those of us that work in dementia care kind of really recognise that, don't we? It's highly skilled, difficult work, isn't it? And Bailey revealed the time and patience it took a support worker to clean the nails clean out the dirt from under a patient's nails while giving him a bath. Next slide, please. So training and teamwork was the next theme. Now, it's not 2 themes because they were linked, because teamwork was a resource for training for the healthcare support workers. So this is why it's kind of one theme. The data, it was quite obvious within the data that there was a whole variability about training and barriers. So people talked about some of the challenges in accessing training, some basic things, not being able to get a computer, not being able to be somewhere quiet, not being able to release, all sorts of things, barriers within training. But then also some of issues around practical delivery, that sometimes training wasn't relevant for the practical skills people needed. In this study by Griffiths, they talked about learning by doing and watching role models and learning from each other. And this next one, I've included this because this in my experience comes up a lot, a belief that person-centered care, was innate rather than taught. It was something about that person, Sylvia is so amazing because it's Sylvia rather than something taught. And I've come across that repeatedly in my career in mental health. And it was also about importance of teamwork. Healthcare support workers in the data tended to identify with other healthcare support workers more strongly than the wider multidisciplinary team, which was interesting. And there was quite a lot of stuff about hierarchies, as I'm sure you can imagine, and some things where that hierarchy of healthcare support workers feeling at the bottom of it could be subverted by other disciplines actually actively seeking out and valuing their opinion, and really some pretty horrible stuff where their opinion was disregarded, sometimes to the detriment of patient care. Next slide, please. And lastly, always being front and centre. Again, this kind of jumped out of the page, really, and just how present the healthcare support workers were on the ward. They were on the shop floor all the time. When people went on the ward, they were often the first person they saw, and they were providing and meeting a whole range of personal healthcare needs, but then also helping with any spur of the moment thing that happened. And on the wards with people with dementia, the spur of the moment things happened quite a lot. So it wasn't just that they went through the tasks that were delegated, they had to stop and deal with this and stop and deal with that. And, that spur of the moment stuff was really, really important too. Next slide, please. So in terms of the implications for healthcare support workers, so clearly, as we've been beginning to talk about, and it's clear in the data, there's high level interactional skills needed for healthcare support workers working with people with dementia in the NHS, but also a lack of standardisation and training and regulation. So different trusts use different things, and they have different in-house training and developed their own stuff for it. So that lack of standardisation. The innate thing I think is really interesting. I spoke to one of the country's leading experts on healthcare support workers who works at King's and about this data, and he kind of went, well, You know, that's so curious, isn't it? Will we ever say that about another profession, that it's innate? You know, where does that come from? You know, and actually it's a really interesting thing, and I think something that we need to unpick a bit. And perhaps it's not so much of a compliment as we think. Maybe there's something in it about not necessarily valuing skills learned and skills crafted. The data said that they were front and centre, yet much of the research says that healthcare support workers often feel invisible in the NHS. This issue about culture and hierarchy, a recent survey found only 20% of healthcare support workers who worked in dementia felt the NHS valued them. And there was also a sense in the data of something that's been written before by Twigg, is this notion of lack of value we place on body work. So working with toileting or washing, there's a kind of lack of value placed in that, on that, despite how difficult it is with people with dementia to deal with these things, actually the value that's placed on that. So that sets up our question quite nicely. You know, how do we notice, value and develop the skills required for healthcare support workers working in dementia care? Next slide, please. I think my slide, that slide just has some of the references. And then next slide, I'm going to hand over to my wonderful colleagues, Kate and Réka, to talk a bit more about the research. Thank you.
Thank you very much. Yes, can I have the next slide, please? There we go. So I'm Réka Polonyi, and I'm with Kate Maguire-Rosier, who's up here and who's going to be speaking after me. We are research associates on this project. Kate was, until recently, research associate as well. So, and I'm going to be speaking a little bit about how we conducted this research. And I think the first thing that's important to mention is that both Kate and I are actually arts scholars. Kate is in dance and disability studies. I'm a performance scholar. And this was a deliberative move to send us, two researchers outside of health studies, into these settings, because we're very well placed to pick up on these more embodied, sensorial and physical qualities of what healthcare support workers are actually doing every day. So for instance, their posture, the volume of their speech, the tone of their voice, their gestures, their movements, the speed of their movements, the kind of touch and forms of touch that they're applying. And these are essentially things that Kate and I have been trained to notice. Another added benefit was that being art scholars also meant we weren't necessarily treated as suspicious or threatening when we approached or were recruiting staff members. This put people at ease very quickly, and it reassured them that we weren't here to supervise or observe or judge their work as being good or bad. So essentially, the format was 16 weeks of data collection across 3 wards in 2 separate sites. And we were using a research method that was highly exploratory and participatory called action research, which uses qualitative data and ethnographic observations. So we observed healthcare support workers in their daily environments on the ward, noting their interactions with patients, but also their interactions with each other and with the space generally. We complemented these observations with what we're calling snapshot interviews during real-time situations to kind of give us a better idea of what they had just done and why. And importantly, we had something we're calling collaborative learning groups. These were 6 sessions, 1 hour each, where we had group discussions and activities with participating healthcare support workers to really best learn from them about their everyday practices of care. And so together, collaboratively in these groups, the aim was to start building a list of sensory skills of care, or a framework of care aesthetics, to recognize these everyday skills that they were already doing on the wards, to kind of lift these skills up and to bring value to them. So there were a couple of challenges in how we conducted this research. We quickly realized, for instance, that care aesthetics as a term is highly academic and not very accessible. It's very confusing. So often when we first approach people on the ward or for recruiting purposes, we would give examples rather than use this term immediately. So for instance, we'd say, we're looking at the way you might touch a patient to reassure them, or the shift in your tone of voice when you're reassuring them, or how you might bend down to reach a patient's eye level and speak to them quietly. And we would often call these the small things you do every day with patients that you care for, or the often unrecognized little things that, despite being little, are absolutely essential for their care. And there are different opinions about whether this use of word little is actually theoretically correct. But in practice, when recruiting and when speaking directly, this was a very good way to bring across what we're looking at. And I think what was really wonderful is that by explaining care aesthetics in these ways, we immediately realized that care aesthetics actually makes a lot of sense to healthcare support workers. It really does. And once we explained what it was, there was often this penny drop moment of, yes, I know what you mean. Is it when, for instance, I do this or I do that? And they would come up with their own examples of care aesthetics immediately on the spot. So this really resonated very quickly with people. Another challenge in how we conducted this research was going from recognizing care aesthetics, which we were just doing, to actually valuing it. And this was a journey. So the collaborative learning groups really gave us a space to kind of stop and note an instance of care aesthetics, something that they did. Like, for instance, it's sitting with a patient in silence while holding their hand. This is a very simple, small moment, and yet it was often, although acknowledged, it was often dismissed or shrugged off as a kind of, well, yes, I guess I just did that. I don't know why, I just do it. And this feeling of I just do it was something we were trying to break down a bit more. So by allowing time to pause on these instances and to reflect on why that moment might actually matter, and giving staff space to reflect on these instances really brought about a sense, we believe, a sense of potentially being seen for the skills that they had and being recognized and valued. So the collaborative learning groups were organized around 3 key questions that we explored together. How do we care? How is it actually done? How do we notice care? And how can we value care? And the picture that you have here on this slide is an example of how we explore these questions. So for instance, by taking a certain everyday act of care, such as shaving that you see at the center, and breaking it down into different acts. What do you do, we were asking. Where do you start with shaving? Starting from how you enter that space. What are you paying attention to? The light, the smell, whether the door is open. How do you approach a patient? What do you say? How do you change your tone of voice, the language that you use, your physicality? How do you approach them? These were all things that we really were breaking down, and you see some examples here. And I will now pass to Kate, who will kind of speak more about what we found and what we noticed.
Thanks, Réka. Next slide, please, Emma. So on screen here is actually some more examples of our data that Réka and I gathered. So these are 4 images taken by Réka and myself during the collaborative learning group sessions Réka's just spoken about, which were held weekly throughout our study with healthcare support workers across the 2 sites in Manchester. So we wanted to show these images to you today as part of this webinar because it gives you some insight into what sort of materials, actions, and I suppose in the end skills that Réka and I were learning from the healthcare support workers. So in one image, a hand holds a red comb. So here, this comb was basically a tool one male participant kept in his pocket at all times, just in case he needed to comb someone's hair. So this portable object, in theatrical terms, right, might be called a prop. It is different from his uniform and other objects in the space, such as furniture. And a prop also refers to a support that holds the position of something else, right? To prop something up, that's a prop as well. So this comb was a sort of prop supporting not just the appearance of people on the ward, but their comfort and, expression. So it's of course not required that healthcare support workers carry combs on the ward. It's not, a mandatory part of their uniform. This comb, was an initiative by this patient, and it showed us that this particular healthcare support worker was giving extra attention to his care of patients. In another image, a participant's hands cup someone else's hand. Here, the healthcare support workers were teaching Réka and myself how they hold patients' hands. We had noticed that during a sing-along session at one of the sites, that one of the participants in our study, a healthcare support worker, would simply sit with another patient and hold their hand like this. So during the collaborative learning group session, we asked this healthcare support worker if they could demonstrate this for us and tell us what they were doing. And so they demonstrated commenting about the pressure of touch, how they held one hand, both the one hand, one on top of the other, and the hand sort of resting rather than clenching or gripping. This is sort of where in the process of doing this, right, we're trying to sort of draw attention to the importance of that gesture, which might easily be dismissed, right, in this setting. In the third image, 4 red and blue squares frame the words, being aware of how others see you. Another phrase is switching gears. The next phrase is peripheral sensorial perception. And the final phrase is knowing how and when to enter someone's space. And these are phrases describing the initial skills in relation to supporting patients to do everyday care acts, like someone finishing their dinner, someone making a decision, say, for example, what you're going to wear that day, or simply keeping patients safe, right? So these are phrases that Réka and I had gleaned after combing through all our field notes from observations on the ward and materials from collaborative learning group sessions. In other words, these words are sort of a glimpse into the beginnings of our framework of aesthetic care that we created in collaboration with the healthcare support workers. And the final 4th image on the right, for me anyway, shows a piece of parchment paper with the words adjusting volume, tone, speed, and style to match a patient in the moment. And this is another skill we distilled from our notes, which were in turn our learnings from the healthcare support workers. So while we are still in the process of group analysis of data like these, for instance, these skills, as we distilled from the context of the collaborative learning group sessions, will not necessarily be the final skills we land on as a team. This is because we are still in the process of thinking through the most valuable way of describing them and categorizing them that do justice to the work Réka and I observed at the sites. But it's also because we're exploring the best theoretical terms from both arts and health literature to account for these sensorial, embodied, and ultimately aesthetic skills. So hopefully this gives you more of a sense of the project, and I'll hand back to John.
Thank you so much. That was so interesting. Thank you. Sometimes you continue to learn on this project even by listening to this webinar. So thank you. It was so interesting. Next slide, please. I've worked in dementia care for over 40 years, and when I first started in dementia care, it was on the inpatient mental health wards. In my time, not everybody was sectioned into the Mental Health Act, but by and large today, on those environments, people with dementia are. So in trying to reach this fairly hidden group, we also wanted to raise the visibility of that group to the wider community. They have largely been hidden away and not part of any national structures or policies or frameworks, which has been quite it's such a shame, because they are the most vulnerable groups of people with dementia, but were probably the least attention. And I must say that even though we haven't shared it too much, the actual ability to obtain ethical approval to actually work on these areas is equally quite challenging. It probably took us the best part of 10 months to a year to gain ethical approval to actually do this work, and to involve people with dementia on Section of the Mental Health Act as part of this research. So, for ourselves, what this research and what James's work has always reminded me of is why I came to be a dementia care nurse. What attracted me to be a dementia care nurse? It wasn't writing lots of articles and going and doing international conference presentations or whatever you might be doing. It was to try to care for somebody better. And I think the language of care aesthetics brings us to the language of very positive person work in dementia. It almost brings the soul back to it. And whilst the words and the work that we've shared has been really, really informative and so helpful, we wanted to turn that into some sort of framework, some sort of applied model for healthcare support workers who, as Jackie said, has had so little attention paid to them over the years. I went back to my own PhD work as a team, and we adopted some of the methodology of constant comparative analysis using Barney Glazer's work predominantly to try to develop a model of care that moved and shifted over time, because that seemed to mirror what healthcare support workers were doing. This was not static care with 4 themes. This was a moving object where decisions were taken quickly on the spur of the moment, as Jackie said. So we needed a model to try to illustrate that, and grinder theory seemed to have the best way of doing that for us at this moment in time, and we did that through a team analysis, both for ourselves as researchers and then through the collaborative learning groups. Next slide, please. I won't dwell on this, but this model is what we've come up with. I'm going to take each of the sections very briefly in the next few moments and just explain each of them. But this is probably within the last 3 weeks been sent off to qualitative health research as for peer review. But it's the outcome that we saw of the data as applied to healthcare support workers, specifically on the mental health wards for older people and for people with dementia. It tried to explain what we saw and what was going on. And I'll just go through it very briefly in the next few moments. Next slide, please. So on the diagram, on the figure, basically on the left-hand side, the foundational aspects that we saw were sensory, embodied and relational practices of healthcare support workers. They were the building blocks on which all care was then delivered, and in which all care aesthetic frameworks were then basically built upon. So we saw the senses being used, sight, hearing, smell, taste, touch. It just informed just about everyday healthcare support worker practices. So how do you do that? So for healthcare support workers, they were really, really clear about changing facial expressions of people with dementia, using touch a lot. And it's very difficult to give dementia care and not to touch somebody. And I think, again, it's that sort of use of the body, not just your body, but the other person's body, and maybe 2 or 3 bodies moving in the same space. So it's dementia, certainly on the inpatient wards, were a perfect sort of opportunity to observe healthcare support workers and their aesthetic approach to care. But touch was used such a lot. Because again, if people needed changing or dressing or a hair washed or a bath or a shower or towel down, you had to do that. You couldn't not do that. So again, healthcare support workers would bend, as Keady and Réka said, they would use their bodies in empathetic and sympathetic ways so that you would be on the same level as the person with dementia. What was interesting was that, again, there'd been no real training about this. It was something that was learnt as a craft of care over the years of care. Next slide, please. And of course, with the senses, they don't just operate individually, they work as a sensory register. So sight and smell and taste go together. There's things that are happening together as a sensory register. And what we picked up really clearly from the data, and also equally from the literature review, was the importance of tuning in. In Glazer's view, it's a basic social process. It's something that really moves. It's there all the time. The whole of the care system and the whole of the care approach revolves around the healthcare support worker's ability to tune in. So it's their senses, it's their intuition, it's their experience, it's their craft, it's their accumulated knowledge to make in the moment decisions or planned decisions. And again, that was really important. A lot of healthcare support workers' actual decision making was in the moment. It wasn't under direction. It was based on experience and their craft. So what we found was that the tuning in process was to the person with dementia, it was to the ward and their colleagues, it was to their values in themselves, it was to their craft of care, and to visitors on the ward. Next slide, please. So this is just one example from the tuning in. So tuning in to the ward and my colleagues. And this is about recognizing an atmospheric shift. And this, because any of us who have worked on wards knows that there's an atmosphere. It's very difficult to put into words and to define it, but we know it's there. We feel it and we sense it. And this particular example was shared with Kate and Réka, basically by a healthcare support worker being observed. And it was seen where the person with dementia was actually in a group and hadn't eaten and drunk for quite some time. And this is what happened. She, the healthcare support worker, leaves the music group. There was an improvised music group going on at that time on the ward. And then she returns holding a cup and a spoon. She stands in front of the patient, swaying to the new tune, and brings the spoon to his lips. The patient is grinning up at her. The healthcare support worker continues to sway to the music, feeding him a spoonful of food every 30 seconds or so, taking her time, singing along until the cup was empty. So it's a very everyday care practice, beautifully framed and phrased, but really the ultimate goal for the healthcare support workers was to feed the person with dementia. Next slide, please. And for us, if you were thinking about what does this all mean? Well, we thought about it in terms of the data, we've talked about it with healthcare support workers, and it's about being co-present. And that was the outcome, that was the descriptive meaning that we put to what healthcare support workers are striving to achieve in their everyday work with people with dementia admitted to these specific care environments. It's about that sort of not just being present, but being co-present, having that interactive nature of presence around you. And it allows you to sit down next to somebody on the city watching television and have that as a valid opportunity to actually practice care, not to be seen as something that is not working, but it actually being co-present alongside the person living with dementia. And we would argue very strongly that it's the epitome of positive person work. Next slide, please. So that's what basically underpins this model of care. We will see whether the peer reviewers like it. We hope that they do. It's taken us a little while to think about it, but it starts to use aesthetic theory and care aesthetic theory to actually provide a framework for healthcare support worker practice. You could argue that this goes beyond healthcare support workers. That's the practice of most care workers of any level of description within NHS or any other care, certainly within care homes, working with people with dementia, with more advanced dementia. But we'd like to think that it's the beginnings of a framework informed by care aesthetics, using some of Kit Wood's language here about positive person work, but actually making it real and visible and valuable for healthcare support workers. Next slide, please. It's very difficult to see. I have broken this slide down, so please don't feel like you need to squint at the screen. But this is thanks to a studio called Jane, who we worked with, because again, the model is interesting in academic sense, but we want to get a much more visible way of representing healthcare support workers' skills and their craft of care and make it visible to others. So we have tried to work with a studio called Jane in Manchester, who's a graphic artist, to produce a infographic about healthcare support worker practice. So that's what we've come up with. I'm just going to break it down very, very gently. Next slide, please. So we start by thinking, what are our everyday care practices? What are they? Well, we're saying it's about using my senses and my body for healthcare support workers. These are examples of the senses: work with the body and work with the voice. Next slide, please. we feel that probably the most valuable thing we can say is to honour and validate and authenticate the skills that healthcare support workers have of tuning into the person with dementia, tuning into the visitors on the ward, tuning into their craft of care, tuning into the ward and their colleagues, tuning into the ward routine, and tuning into themselves and their values. I think it's probably very fair to say, but it's quite a difficult thing to talk about, is that we didn't always see healthcare support workers work largely as teams supporting one another. It would be lovely if there was more structured supervision time, but healthcare support workers that we saw within both in the literature and a little bit within our own study, they got support from themselves. So I think there's probably other work to be done around this area. But healthcare support workers are very clear about what type of training they want, and that's maybe a more advanced and more seen role on the ward. Next slide, please. And ultimately, just like we have on person-centered care, possibly the what links this all together, what gives voice and reason and rationale, is for the healthcare support workers being co-present alongside people living with very advanced dementia in those specific environments of care. And that is something to strive for, and something that's very important and gives a goal of care. Next slide, please. So we've submitted the, just a final thoughts, so we've submitted the paper to Qualitative Health Research. We don't know whether it's going to be accepted or not, but this is the working out behind it all. We'd like to use the model as it's being developed for further refinement, testing and training. We basically think that care aesthetics provides a framework to analyse the micro processes and practices of care. So, yeah. So as we said about the focus on play and stimulation, things that are very, very rarely written about, seen in Kitwood's original work on positive person work, but not really talked about. We saw a lot of play happening, really creative play and improvisation. And again, with Kate and Réka being from the arts background, the focus on creativity and innovation and improvisation was really strong, and possibly a way of thinking about reframing some of this care practice. And also, we'd like to think that care aesthetics, and certainly through some of the work that we'd like to put forward, starts to validate and authenticate the importance and human value of simply being alongside people living with dementia. That in itself, sitting quietly, is an art and a craft in itself. Being together is an art and a craft. And having that validated as a legitimate outcome of dementia care practice would, for me, be a very useful way to end my own career. Next slide, please. Huge thanks to everybody who's taking part in the project. It goes beyond those that are named here, but particular thanks to Emma, Susan and Rob for allowing us to have this moment in time to share with you this webinar and our own work. And also, again, it's not quite here, but thanks to a studio called Jane as well for the infographic. And thank you as well for listening. Next slide, please. Thank you.
Thanks, John, and thanks to all the presenters. That was such a fascinating presentation, and yeah, a really interesting topic and such an important piece of research. We've got about 10 minutes left for questions. So if people who join the webinar want to add a question, as I say, there's the Q&A button at the top. If you just want to add your question there, I can read it out. So there's I've got a couple of questions already. So one from Sharish, and a slightly verbose one from me that I'll ask if nobody else asks questions, but if I'm willing to give my question up if other people have more pressing ones, because I can ask John another time. But the question from Sharish is there a limit when applying care aesthetics in terms of a person's functionality and acuity? So I don't know if one of the panel would want to pick that up or has any thoughts on that.
Shall I just say one thing quickly, and then I'm happy to hand over to others. I think one thing originally about care aesthetics is it was looking at the full range of bodily practices that a carer and a care recipient bring together in a care experience. So if someone has more profound cognitive impairment or profound disabilities, for example, the way someone tunes into their needs and their requirements is really important, obviously, and it requires a whole range of bodily practices. So I think care aesthetics is about tuning in to what a care relationship needs, and actually acknowledging the different capacities of people you're working with. So if someone has a profound disability, actually fantastic carers are able to tune into what is possible in that particular circumstance. So I wouldn't say that I think the aesthetics of our care are stretch and relate to the actual needs of a particular person. So and in severe cases of disability, or and also in people living with dementia, that process of micro tuning in becomes even more acute and important. I don't know, other colleagues might want to say something.
I agree, James. I think it for me, it applies to people at any stage of dementia, and obviously people with very advanced dementia, you're looking more at touch, aren't you? And those very embodied things. So I think it's got across the board. I think it's actually got applications for other areas of mental health as well, because I can think of the support staff working on functional wards or working age adult wards, the way they work with people who are extremely distressed. I think there's a lot of application, not just to this client group. So I think it's about the relationship, isn't it? And that's what I mean about it. It speaks to interaction, isn't it? Where we alter what we do depending on the person that we're doing that thing with, don't we? So we're tuning into them and the situation, and they are, and it's very much in the moment, isn't it, in that kind of sense. So I agree totally, James.
Great, thanks, Jackie and James. Compliment from Alexandra about the presentation. I've heard her soul today speaks to her greatly, which is a really nice comment. There's a question from Rebecca. I love that your observations of this challenging work by healthcare HCSWs are so positive. I work on these wards, and I wonder if you saw evidence of a reluctance to touch patients when there was a risk of the staff member being hurt because of patient distress. So I don't know if that's something that came up in the course of this study or something you want to speak to.
I can talk to that. We didn't actually witness something like that, but the idea of sort of safety was a really strong theme in the collaborative learning group sessions, and we have one collaborative learning group session was about how you stand in order to sort of have a friendly demeanor, but at the same time you're in a secure, stable position in case a patient is exhibiting what we call behaviors that challenge, right? So that did come up, but I didn't witness. I'm not sure if Réka did either, but yeah, thanks for the question.
I think it's an important question, isn't it? Because it kind of I think that's why we need to observe these settings in depth, because people say all the time, well, we must use this or must use that. But the complexities of it are much more challenging, aren't they? Using touch at the right moment, because obviously sometimes you can touch people and it's really the wrong moment. Now is not the time to touch them, isn't it? And there were examples where healthcare support workers use their bodies to protect other patients. You did have an example of that, didn't you? Where a healthcare support worker deliberately almost like gets kicked themselves to stop another patient getting kicked. And I think it recognises some of the physical challenge that's required within this work too. So yeah,
brilliant. I think we're out of time in terms of questions, but maybe if you have the next slide, there's a few more questions coming in. So we've got contact details there. So I guess if people want to continue the conversation after the webinar, people's contact details are there.
This is a shameless plug for research and innovation at GMMH. We have put a lot of work into providing resources online about studies that we are currently running, sponsoring, being a site for. You can look at our gmmh.nhs.uk/research-innovation, or follow us on many of our social media platforms We've got a library of all the studies that are currently recruiting or in follow-up and writing their papers, of so many different conditions and approaches, pharmaceutical and interventions. It's really interesting to have a look at the variety. So please do have a look if you've got some time. Thank you.
Thanks, Emma. So I think we're almost at time, and I'm sure people will need to scoot off. But yeah, I just want to say once again, a final thank you to all the presenters for presenting their work. It was great. Lots of compliments in the chat. Thanks also to Susan and Emma for doing all the heavy lifting behind the scenes as well and setting everything up. So hopefully we'll see you at one of these events again in the future.